Dear students, over the next 15 to 20 minutes, I shall be covering an important topic which shall be an essay or a long short note. Carcinoma of the liver. Whenever I mention the word carcinoma, for undergraduate students, there are two major malignancies. One is hepatocellular carcinoma and two is cholangiocarcinoma. Remember these two fundamentally: hepatocellular carcinoma and cholangiocarcinoma. And this is the list of liver tumors which we shall try to memorize. There is a hepatic adenoma, a benign tumor, a hepatocellular carcinoma, biliary carcinoma or a cholangiocarcinoma, hepatoblastoma, angiosarcoma, lymphoma, metastatic tumors, and hamartoma, such as a hemangioma, etc. So this will be the list of tumors. You might be asked, enumerate the list of hepatocellular tumors. And this is a specimen of the liver. I need not point out this nodule to you people. It is smooth, it is shiny, it is well demarcated, and to me it appears capsulated also. It is a hepatic adenoma, a benign tumor. So you people will have to by heart this list. Coming to the etiology of hepatocellular carcinoma, the first one. There are a number of causes. Hepatitis B virus infection until some time back was a major cause. But now hepatitis C virus has overtaken it. There is also a vertical transmission from the mother to the child. There is another condition called as post-necrotic cirrhosis, which can pave way for hepatocellular carcinoma. A brief word about the pathogenesis. There can be what is called as insertional mutagenesis. There is a mutation that is caused in the chromosome, later on leading to uncontrolled malignancy. Also, in any of the hepatic disorders, there can be destruction followed by regeneration of the parenchyma. This can result in malignancy. And the last hypothesis is a damaged hepatocyte is itself vulnerable to carcinogens. So three things: insertional mutagenesis, regeneration leading to malignancy, and damaged hepatocyte being vulnerable to malignant carcinogens. What are the other causes? For hepatocellular carcinoma, this is the list: aflatoxin B1, primary biliary cirrhosis, hemochromatosis, alpha-1 antitrypsin deficiency, Wilson's disease. These we shall be covering elsewhere, and these are all questions for us also. So it is easy for us to remember. Regarding angiosarcoma, a tumor of the blood vessel, two important causes are there. One is R.A.T.S, another is vinyl chloride. So this is a crop, and I find that there are some blackish areas of contamination that is. This is a fungus that has grown in it, namely Aspergillus flavus. And this will be producing what is called as aflatoxin B1. So the major source will be the grains stored in the granary, which are contaminated with Aspergillus, which can produce aflatoxin B1. Now, what is this maze of pictures over here? This is a Torah trust. It has been banned because it was leading to malignancy. And remember the vat of chemicals, vinyl chloride, arsenic, and Thoratrest. All of this can lead to a malignancy called angiosarcoma, a malignant tumor of the blood vessels. And this is a tumor proper, but in the background, I am finding a fine nodular appearance, which means cirrhosis. So it can occur in a background of cirrhosis. And in this particular liver, what is striking is a greenish hue. Probably there is some biliary stasis and then a malignancy out of it. So these are some causes for hepatocellular carcinoma and angiosarcoma. Describe it. This picture I had posted purposely because in some colleges there can be a case of, look at this granularity or nodularity in the background. It is cirrhosis, obviously. And then there is a tumor. You can be given a specimen of cirrhosis with malignancy. So it is a mixed nodular cirrhosis that I am seeing throughout. And there is a well circumscribed lesion, but it is showing some areas of hemorrhage and necrosis. It is a hepatocellular carcinoma. Coming to the gross of hepatocellular carcinoma, basically there are some fundamentals. The liver weighs up to 3 kg. It can be 2 to 3 kg, increased in weight. And the types of malignancies can be diffuse, solitary, or multifocal. And there can be a greenish hue because of bile stasis. Look at this picture over here. There is a large tumor. It is well circumscribed. Circumscribed and capsulated are two different words. Circumscribed, I can draw a circle around it. Capsulated, it is an intact covering. So it is circumscribed. The tumor is grayish white, but then there are areas of hemorrhage, necrosis, and the large size itself should make us suspect a malignancy. It is a diffuse type of hepatocellular carcinoma. And this we had seen in one of the first pictures, a well circumscribed tumor. It is a hepatic adenoma. I had purposely reposted this so that we can compare an adenoma with a carcinoma. Both are specimens of liver. In this liver, I am finding a large tumor. Again, it is circumscribed, and in spite of that, I am able to see some nodules outside. I'm able to see some nodules outside. These are called as satellite nodules. Just like some satellites that are surrounding the planet, you find that there are some nodules which are surrounding the major malignancy. It is a large friable growth with satellite nodules, a hepatocellular carcinoma. Both the pictures are from WebPath. This again I have posted for comparison. Here I am finding a normal liver. I need not describe it further. Whereas in this, I am finding a large tumor. There are areas of hemorrhage and necrosis. It is friable. It is somewhat pinkish white or grayish white. And there are nodules which are seen outside also. So frankly, this is a malignancy of a liver, a hepatocellular carcinoma. Compared to the previous pictures, here I am finding multiple nodules which are again somewhat yellowish gray, etc. And this is what is depicted in a diagram. You can draw this actually. I am finding it in multiple places, so it is called multicentric. So multicentric is the word. Please do not mistake it for a cirrhotic nodule because cirrhosis will be seen throughout the surface of the liver and not in certain areas. Regarding the histology of hepatocellular carcinoma, it can be well differentiated. Well differentiated means it mimics the original tissue. Anaplastic, highly frightening variation in size, shape, increased mitosis, etc. Trabecular, this is one of the classical patterns, and that is what I am seeing in the picture over here. I am finding that there are about 3 or 4 cells in breadth, and they are all forming long cords. This is called as trabecular. Long cords of tumor cells arranged in broad breadth of about 3 or 4 or sometimes 5 cells. Pseudoglandular. A hepatocellular carcinoma is not an adenocarcinoma, but here I find that there are some areas of necrosis within the nest. So it appears as though it is a gland with areas of necrosis. This is called pseudoglandular. Another variant is a clear cell. Just like the kidney renal cell carcinoma, we will be finding clear cytoplasm. Fibrolamellar is one that we shall be seeing next. So kindly go through these pictures, particularly the trabecular form of hepatocellular carcinoma. Mallory bodies incidentally can be found in a number of conditions. So this can be asked as a differential diagnosis or an MCQ, mainly in alcoholic liver disease, but then it can occur in Wilson's disease, hepatocellular carcinoma, etc. This is a beautiful diagram which I would like you people to kindly draw, retrieved from illustrated pathology. I am finding cords and broad bands of these trabeculae, and the nuclei are enlarged. There is some variation in the size of the nuclei. Some are small, some are large. And in some areas, I find that there is some areas of secretion that I can see within the hepatocytes. So this is the hepatocellular carcinoma. So this again is a diagram very easy for you people to draw. A solitary form of a tumor, and here it is multifocal. So in multiple areas we see this, and in this almost the entire liver surface appears to be covered. So it is called as a diffuse form. Solitary, multifocal, and diffuse. Please remember this and draw this. This is the fibrolamellar. In fibrolamellar, again there are cords of these tumor cells, and they are separated by fibrocollagenous tissue. So look at this one, the fibrocollagenous tissue. But this type of tumor, it is supposed to be carrying an excellent prognosis. In fact, the MCQ will be which of the types has got a good prognosis, and it will be fibrolamellar. Better prognosis occurs in younger individuals, not associated with cirrhosis, a cord or trabecular-like pattern, fibrostroma. All are given in the pictures. So please recollect and write. In one of the universities, they have asked this as a short note, though it is not a favorite question of mine. And this is the gross picture. I find that the tumor is dipping down because the fibrous is contracting. So there is a fibrous tissue, there is a contraction, and there is a large tumor over here, in spite of which the prognosis is good. Fibrolamellar carcinoma. A hepatocellular carcinoma is over here. Look at the broad trabeculae. Not just 4 or 5, I find that several cells are there, and they are arranged in cords and which are anastomosing. It is a trabecular form of hepatocellular carcinoma. Here, I am able to see the normal liver tissue. The normal liver tissue is here, but I am finding multiple glands. They are well differentiated, elongated glands, and it is a cholangiocarcinoma. Look at this gland over here. It is a cholangiocarcinoma, which we shall be seeing. So the microscope is, the cells are in hepatocellular carcinoma. They are polygonal or hexagonal, resembling the hepatocytes. It can be well differentiated or anaplastic. The various patterns are trabecular, glandular, pseudoglandular, and a fibrolamellar pattern. Malarious hyaline can be seen in some. What do you see in this picture? So again, I find that there is a diffuse kind of a tumor, all are nodules, and there is something that is happening in this nodule. What is happening? If you cannot identify this, I hope you people will be able to identify this, the umbilicus. So I find an umbilicus like dipping. This is called as umbilication. The dipping in due to fibrosis and necrosis. Classical of hepatocellular carcinoma. And what are all the routes of spread? It can be via the portal vein or the hepatic vein. These are venular modes of spread. In fact, by means of the hepatic vein up to the inferior vena cava to the right side of the heart, just like the renal cell carcinoma. There can be a lymphatic spread, which can be, remember the three P's, perihilar, peripancreatic, and para-aortic. Three P's, which we shall remember. These are all the modes of spread of hepatocellular carcinoma. The next major tumor will be the cholangiocarcinoma. It occurs in individuals over 50 to 60 years, associated with steroid administration. R.A.T.S is one. It is a contrast dye that was used for X-rays. It has been banned, that was resulting in malignancies. Another important cause will be the liver fluke or Clonarchus sinensis. It is a picture of it, and it is colloquially called the fish tapeworm, and this is the egg of it. More of a parasitology topic, but then important. This can cause obstruction of the biliary duct and then lead to malignancy. Any congenital anomaly of the biliary duct, strangely, ulcerative colitis can be associated with cholangiocarcinoma. Always when you describe the cholangiocarcinoma, you score a point over others. So this is the etiology, and just one etiology I have highlighted. Grossly, the tumor can be nodular, or sometimes it can be having finger-like projections. Microscopically, the glands are well differentiated with cuboidal to columnar lining. The spread will be almost the same as hepatocellular carcinoma. There can be a venular spread, there can be a lymphatic spread. Please remember that. And the clinical features will be it results in biliary obstruction, there can be jaundice and cirrhosis. The invasion again, it has been mentioned. These are all the various causes for or the routes of invasion. Please remember the three P's: perihilar, peripancreatic, para-aortic. This is a picture of a cholangiocarcinoma. So the tumor is almost well demarcated. It appears to be having lobulation. And here again, this is a normal liver. L is the normal liver. You people can take a closer look of the normal sinusoids. And this is a carcinoma. Look at the irregular strands and the glands which are infiltrating into the liver parenchyma. So this is a cholangiocarcinoma. How do you diagnose? In fact, cholangiocarcinoma or hepatocellular carcinoma. Hepatocellular carcinoma, there is an elevation of alpha fetoprotein. Otherwise, radiology, the CT and MRI are important tools in diagnosis. ERCP, endoscopic retrograde cholangiopancreatography. A long word, we shall try to remember. They put in a tube, they go up into the common bile duct, they can go up into the liver up to that area, and they can identify a tumor which is called as cholangiocarcinoma. Cholangiocarcinoma, okay. And they can also take a photograph of it or a biopsy. In fact, the ultimate tool will be the biopsy. For the liver, we can take a needle biopsy, and for this, we'll be able to put in an ERCP and take a biopsy as well. This is a metastasis. I find that the liver has got multiple nodules. Some of them are again showing umbilication, and I have asked you what the DD is. In the liver itself, we have mentioned that there is something called as multicentric. The hepatocellular carcinoma can be in multiple areas. So That can be a differential diagnosis for us. And metastasis, one favorite question of my teacher, why is metastasis to the liver more common? More common. That is because it has got a dual vascular supply. So you have got the systemic vasculature as well as the portal circulation. Two circulations are there, and hence both the liver as well as the lung are prone for increased amount of metastasis. And the routes of spread I have already told you. And hematogenous, that can be the lung, bone, and adrenals. These are some of the common causes for cholangiocarcinoma. And finally, this is a tumor. Before it spreads elsewhere, it can spread within the tumor itself, liver itself. So this is one. Please remember this. And I mentioned this earlier. Vascular, hepatic vein, inferior vena cava up to the right atrium, almost similar to the renal cell carcinoma. The common sites of metastasis are already mentioned. And this is a summary. A long has been spoken, but then we have spoken about the classification, what are the causes, gross and microscopic picture, the role of R.A.T.S, and umbilication, diffuse, unicentric. These are all the various types that we had mentioned. Polyvinyl chloride, which is used for making the pipes, is again a source of an angiosarcoma that I had mentioned in the list. Spasiba. Thank you.